Good evening, everybody, and welcome to the African Ancestry Experience. This is where we discuss how we as Black people view ourselves and we view Africa. Tonight, we're back with another important discussion about the role of genetic counselors in the genetic disorders amongst African Americans. African Ancestry's own co-founder, Dr. Rick Kittles, and his colleague, Barbara Harrison, a certified genetic counselor, are here to break it down. You don't want to miss this, so stay tuned, because I want to know you.
I wanna know ya, Cameroon, Guinea-Bissau, Sierra Leone, gotta let me show ya, Nigeria, Bioko Island, Liberia.
It's good to see so many of you all with us tonight. Shout out to Yahosef and Norma, I Am Bolt, and all of you joining us on Facebook and on YouTube. Those of you watching us in the replay. The African Ancestry Experience is all about sharing identity-focused conversations with the African diaspora. So over here, we're about tracing your DNA, finding your roots, and exploring who you are. Now, if you're African Ancestry online community family out there, put your country's flag in the chat. Let us know that you're here. And if you're a new African Ancestry family member, you have to join the AAOC on Facebook. We're over 8,000 deep now. We are inching our way towards 9,000. So we want you to go over there and join in the conversations where people are sharing resources, sharing information, and celebrating their people and countries of ancestry. Now, many of you all are at different stages of your African ancestry journey. So if you haven't taken a test yet, I recommend heading over to our website, AfricanAncestry.com, to take advantage of our Mother's Day offer. So you can use the code MOM22 and save 10% on any African Ancestry test kit. And it's not too late to celebrate your mother for Mother's Day. So why don't you go ahead and get that kit and start the journey to finding out where you're from. And then if you're an OG, you can get some good info over on the website as well and share with people that you know who've been asking questions. So you can check that out at AfricanAncestry.com. Every Wednesday, we give away African Ancestry swag to the first person to join us after 7 p.m. So Broderick Jones, congratulations. You get our new royalty. I got royalty inside my DNA. If you all were on for the National DNA Day discussion, you saw us debut this shirt when we had a conversation with those 4 tremendous scientists. I want you to like us, share, subscribe. Most importantly, turn on the notifications so you won't miss a single episode. We started this, actually, I'm getting ahead of myself. Why don't we bring Dr. Kittles in there? I think this would be a good time. You know, on the first show of every month, we bring in my co-founder and business partner, Dr. Rick Kittles, to help us with the science conversations. And so he's here with us tonight.
Hello.
Rick.
Hey, Gina. How's it going? So funny. What's so funny today?
Oh, my God. You're hilarious. I never get this great reception on a day-to-day basis. I look forward to these Wednesdays where you're like, hey, Gina. Anyway, I'm glad to have you back here on the African Ancestry Experience. I want to see you put some DNA emojis in the chat to welcome Dr. Kittles with us. The first of each month, Rick, you were instrumental in this. We're providing science-themed programming that educates the African Ancestry family about the role that genetics plays in the health and well-being of Black people. And this week, you were adamant. You were like, you have to have Barbara Harrison. She's played an instrumental role in my career. Tell me about that.
Well, when I started my career as a faculty at Howard University, it was a great experience. It actually helped shape my identity as a Black geneticist. And there were many people there who had very interesting roles that I learned were instrumental in understanding and taking care of people of African descent. So one of the roles was the role of a genetic counselor. They study. They don't study. They actually work with patients who have genetic diseases or genetic disorders like Sickle-cell Disease. And so at Howard University, I don't know why I'm going into all this. I should have her talk about this.
Okay, well, listen, I'm going to jump out. I'm going to leave you to it, and then I'll be back for Fact or Whack.
Okay, well, and I always enjoy talking to the African Ancestry family. So this is going to be a really good session. I want you guys to just sit back and listen and throw some comments in the chat. So right now I'm going to dive right in and welcome Barbara Harrison to join us in this conversation. Hey, Barbara.
Hello, I'm just so happy to be here, and I definitely can't outdo that intro.
That's right. Okay. So Barbara is a certified genetic counselor and assistant professor at Howard University. She teaches students, medical students, graduate students, and medical residents in various specialties in the areas around genetics and genetic testing and genetic counseling and ethics. So why don't you just briefly introduce the term genetic counselor and what that means to our audience?
Mm-hmm. Sure. So hello, African Ancestry family. I'm just so thrilled to be joining you this evening. So genetic counseling is really a field. It's a career choice. It's a position where essentially genetic counselors are able to translate, to make sense out of genetic testing for individuals who may be facing decisions around whether or not to have a test. Genetic counselors also talk to families about conditions that are present in their family and trying to figure out how does that affect their own chances to develop those conditions. Genetic counselors also work with families. Let's say if there's a child who has several things that are different, maybe has learning disability coupled with a heart issue, and trying to put all those pieces together to say what is the bottom line cause of this condition that we're seeing and what does that mean for that person's future. So oftentimes we're helping individuals understand what's going on with themselves, what's going on with their health, but on different levels. Sometimes it's because of family history, sometimes it's because of what's going on with themselves. And sometimes it's that a particular condition isn't necessarily known to be in the family. We haven't seen it in the family, but we know that the genetic information is there that could cause that condition in the future. And so sometimes it's those predictive conversations that we're having.
Okay. So how did you become a genetic counselor? Sort of what made you want to become it, and then sort of what was that process?
Mm-hmm. So when I was in undergrad, I knew that I wanted to be in the health field. I had an interest in genetics, and even had an interest with sickle cell. I have family members with sickle cell. And so I knew all those three things were going on in my mind, and I wanted to do something that might combine those. But the only real career choices that I knew of in the health field was being a doctor or being a nurse. And I really didn't know much else. So as I was nearing the end of my undergrad career, I figured, well, maybe I'll just stay in school a little longer till I figure that out. So I actually went to talk to programs or talk to schools about getting a PhD in genetics, because again, I knew I had that interest in genetics. But when I was talking to them, they would ask me, what do you want to do your research on? And I had done, work in the lab before, but I was voicing this interest of talking to patients and working with people who had genetic conditions. And I got some pretty strange looks until I came upon one person who asked me if I had ever heard of genetic counseling. And this was in the early 90s. Genetic counseling was still a very young field at that time. And I'd kind of heard about it, but not anything concrete enough to really see myself as a genetic counselor. But I had the opportunity to talk to a genetic counselor at that time. And that was kind of going right into my senior year. So I started, back then it was mailing and phone calls to try to get more information, and found myself into a genetic counseling program, which is a master's degree. They're typically 1.5 to 2 year programs to do that. And so coming out of that, it was armed then to be a genetic counselor. It was interesting at the time. I didn't think a lot about these, future ramifications of being a genetic counselor. I'm so glad I'm in the field and really have been a part of that. I also didn't appreciate really at the time, I think, the issues around diversity. That's something I think that I really came into during my training and then after my training. I can't say that was something I knew kind of from the beginning, but has definitely developed since that time. And again, just definitely feel blessed to be in the position that I am now.
Okay, great. So you had mentioned sickle cell disease, and that is a genetic disorder, and it is one that I guess families would engage with a genetic counselor even before the child is born. The opportunities for discussing this with individuals. So can you talk a little bit about sickle cell and sort of what that what some of that engagement with family would look like?
Sure, yeah. So so the relationship between genetic counselors and sickle cell really span the whole lifetime, right? So you have couples who may be interested in becoming pregnant, and either through testing that's done just before getting pregnant or while they're pregnant, find out that that both of those individuals have sickle cell trait or are carriers, and therefore there's a possibility they could have a child with sickle cell disease. And so that conversation at that point might start while they're pregnant, again, may start before they're pregnant, to involve, talking about those risks, talking about the options as far as testing, either in pregnancy or after after delivery, or even before becoming pregnant, and trying to engage some control over whether or not an embryo has the genes that would cause sickle cell disease. So all those things might be part of that conversation. And then in childhood, early adolescence, I've certainly found myself talking to younger folks about sickle cell disease in high school and middle schools, just raising awareness about the condition, what it means to have it, how it affects loved ones, friends who have it, and helping to engage people in that discussion and remove some of the stigma that has been associated with the disease, and trying to really address that in early. And then you have individuals who have sickle cell, as they get through childhood, through adolescence, and even into adulthood, who have their own thoughts about having children with sickle cell disease themselves and wanting to know more about those chances. And so engaging in those discussions, and, of course, it's quite varied what people decide in those moments. But that's really the purpose of genetic counseling. It's really about having those conversations, and having those conversations in the context of what's important to that person, that individual, or that family, or that couple in that moment.
Right.
So I can talk to two different couples in the same situation who make very different decisions about what they do with that information. And the role of the genetic counselor is really to empower them to have the information that they need, and then help them with that conversation, as needed, to determine the best steps for them.
Right. Okay, so why don't we tell the audience, because I think we talked a little bit around this, what exactly is sickle cell trait or disease, really?
Sure. So we know that sickle cell disease is a condition of the blood. So just to talk a little bit about the kind of what causes it. So in our red blood cells, there's hemoglobin, and hemoglobin carries oxygen. It's kind of its simple job. But I tell people when I talk to them, just like we have different eye colors, different hair colors, different skin colors, there's different types of hemoglobin. So most people have hemoglobin A, operates like we expect it to. But then the next most common type of hemoglobin is hemoglobin S, or sickle hemoglobin. So this is just another variation of hemoglobin. And it carries oxygen, but when it loses its oxygen, it acts differently. It starts to stick to other pieces of hemoglobin in the cell. It causes them to become rigid, take the sickle shape or the crescent moon shape. And then that goes on to cause various issues. Most significantly, I guess, is the sickle cells getting clogged in the small blood vessels, which then cause a blockage of nutrients, water, oxygen, getting to whatever's on the other side. And the way that whatever's on the other side, be it a muscle, bone, tissue, organ, the way that that's going to let the brain know something is wrong is pain.
Yes.
So we know that individuals with sickle cell have, significant pain. So just like with every other protein or substance or process that goes on in our body, we have our genetic information that controls that. And so your body knows what type of hemoglobin to make through your genetic information.
Mm-hmm.
So if you have the instructions from both parents, because I know our African Ancestry audience out there knows that we get our genetic information equally from the egg and the sperm. So if the information we got, let's say from the egg, was for hemoglobin A, and the information we got from the sperm was hemoglobin A, then that person just has instructions for hemoglobin A. They make that hemoglobin, no complications.
Mm-hmm.
But if that individual receives information for hemoglobin S from both parents, then all their body knows to do is to make hemoglobin S, or that sickle hemoglobin. And so they're going to end up having sickle cell disease. And so when we say that is SS, because they got an S from both parents.
Right.
But then you have individuals that got hemoglobin A from one parent and hemoglobin S from the other parent. Mm-hmm. And so those individuals, we say, have sickle cell trait. Has been kind of the common name for that. Kind of more officially, we say it being a carrier for sickle cell disease. But regardless, that person has those instructions for hemoglobin A. Their body kind of figures out that works better than hemoglobin S. So, in general, they make more hemoglobin A than hemoglobin S. And oftentimes they don't have any medical problems. Right. Rarely, we have seen some people, of course, with sickle cell trait that have some complications if their bodies are particularly stressed. But generally, they're healthy, and people have sickle cell trait and don't know it unless they specifically have that testing. And then just before we leave that conversation, just to say that there are other types of hemoglobin besides hemoglobin S. There's hemoglobin C and hemoglobin D and E, and the alphabet soup and other names for all these different types of hemoglobin, which, if combined with hemoglobin S, can cause other forms of sickle cell disease. But anyway, that's the difference kind of between that sickle cell disease and sickle cell trait.
So this beta globin gene that actually codes for that for the hemoglobin, and one of the pieces of hemoglobin, the entire molecules, I think it's 4 subunits.
Yep.
So the beta globin gene, the beta globin gene has this variant, a genetic variant, just a change in one of the nucleotides, one of millions that we have, right? Yeah. And that code in every cell of our body, except for the red blood cell. And that variant has a history, right? And the history is of that variation of that particular genetic variant, is centered around West Africa, West and Central Africa, right? Mm-hmm. And so that is why we see the prevalence of sickle cell disease so high in African Americans and people of West African descent. And I think that was one of the questions that somebody just raised on in the comments section. What I find interesting is, as I started looking into exploring sort of the genetics of sickle cell disease, you find that there's other variants that are also in that same gene that lead to other forms of the blood disorder, mm-hmm. as you said, and some of them are unique to particular regions of the world. There's like this Mediterranean. Yeah. There's some from North Africa, and then West Africa. There's several subtypes, and Central Africa. There's another one. So I find it's interesting that because of population history, certain things happened in certain communities that gave rise to the increase in prevalence of that variation. Meaning that normally the variation may not stay in the population long, but in West Africa it actually conferred some benefit. Yeah. So that the actual variation, genetic variant that contributes to presently sickle cell disease, had some kind of benefit back early on in West and Central Africa. You know what that benefit? I guess, of course, you know, but would you mind telling me what that benefit is?
Yeah, absolutely. Lead me right into that one. Yes. So, so individuals that have sickle cell trait, and as you mentioned, other variants of hemoglobin arising out of that, those variations in beta globin specifically, do confer a protection against malaria. So in areas of the world where malaria is present, individuals who have sickle cell trait are less likely to come down with the full, malaria disease infection and succumb to that disease, and instead survive. Right. Now, individuals that are hemoglobin AA get malaria and, very well don't make it. Individuals with sickle cell disease or who are already, their bodies are strained, having malaria is not going to be helpful. But individuals with sickle cell trait survive. And so, for generations, this variation has been protective. And one of the ways we also see that evidence of that in how important it is to study individuals of African descent is even when you look at the specific variation that causes hemoglobin S, it occurred in different places on the continent individually. So it's not like just one person had this and spread it. It happened in several different places. But we can trace that through, even more sophisticated genetic testing where we can kind of check, go through haplotypes and identify where that variant originated from. So I think that's even more evidence of the richness of the information that can come out of studying individuals of the African diaspora.
Right.
But anyway, but to your point, yes. And so in Western Africa specifically, sickle cell disease is quite prominent, and sickle cell trait really more so. So whereas in the United States, usually say about 10%, 1 in 10, 1 in 12 individuals of African descent have sickle cell trait. If you go to Nigeria, Ghana, other areas, that number can be as high as 1 in 4, 1 in 5 individuals with trait. And then we know because of the history of the transatlantic slave trade and knowing that the significant numbers of individuals in the United States came from that area, from West Africa.
Right.
That's certainly how it originated here, not originated here, but, perpetuated here. Right. And now, in the United States, we don't have that pressure of malaria, but there's nothing to keep individuals with sickle cell trait from procreating or people even with sickle cell disease. So that gene has persisted.
Right. And so the actual variant is inherited as a recessive allele. And so you need 2 copies in order for the disease to manifest, right? You can have a child born with 1 copy of it, and they will be a carrier. We call them the carrier trait, right?
Right.
But you need 2 copies in the child for it to manifest. So the question is, I think back in the 50s, there was sort of there was a lot of policy around sickle cell in the 50s and 60s, actually the 60s, and during the mid 60s, in particular, late 60s. And there was a lot of genetic testing going on for sickle cell in African Americans. Where is the country at now? Is that still very common to test for sickle cell in children or even before individuals get married?
Yeah, it's actually really, I think, important that you brought that up. The 60s and 70s really was a very active time, particularly with the Black Panthers, really spreading the word about sickle cell disease, taking it on themselves because there wasn't the attention being given to sickle cell disease by the federal government. That the Black Panthers really started those efforts to do community awareness around sickle cell disease. And then even we're reaching an important milestone this year. In 1972, so 50 years ago, President Nixon signed the National Sickle Cell Control Act, really because of a lot of the pressure that the Black Panthers were bringing from a political standpoint, as well as doctors like Dr. Roland Scott, who I just have to shout out, being the founder of the Howard University Center for Sickle Cell Disease. But many physicians at that time were saying we can't continue to ignore sickle cell disease, which it largely had been. And there's a whole, pretty history around that. But in any case, so testing was very active then. Unfortunately, there was a lot of misinformation as well, where, children were getting tested in schools. And then if they had sickle cell trait, they were being labeled as having a disability. People were losing their jobs because testing was being done. It was really used as a way to perpetuate institutional racism at the time, discrimination, and so forth. So now where we find ourselves is that there is newborn screening. So in the United States, every newborn is screened for sickle cell disease. And those with trait may or may not get that information. Sometimes it's just a letter that's sent home saying that, your child has sickle cell trait and no one else really talks about it anymore. But that's, really kind of state specific, but regardless, the testing is done. And again, prenatally, there's a level of screening that is done. It varies as well, but there is a level of screening that's done for sickle cell in all pregnant women. And some of that testing is good. And in other words, it's pretty detailed. It tells us about all the different variants, but there are still some clinical practices that just do a very simple test, only looking for hemoglobin S and not for anything else, which is really incomplete. So we still have a ways to go, for sure.
So just to back up, so what you're saying is that every pregnant woman gets tested, every African American pregnant woman gets tested for prenatal testing for sickle cell.
So actually, it's not just for women of African descent. There is a recommendation that all women have what's called solubility screening, or some screening just for hemoglobin S. And then if a woman is known to be of African descent, Mediterranean descent, there are some guidelines to provide even more extensive screening beyond that. Of course, as you've learned doing your work at African Ancestry, using skin color as a way to judge what your genes are is not, and by far is not an exact science. And so we are certainly missing individuals by just using that, because, we say African descent, and really what we're kind of meaning in our mind is we're still going by skin color, and and it's just not accurate.
Right. So the, I guess those could be some difficult discussions. When parents are coming in for prenatal testing and they get the results back, I'm sure there's a lot of anxiety. And let's say results come back and the child, the fetus has a what do you call it? A trisomy, like 3 instead of
Down
2.
syndrome or something.
Yeah, it's something like that. Some trisomy syndrome. And how difficult are some of those conversations? Like you said earlier that you don't give them any, you don't tell them what they should do, but you give them sort of a good set of information or knowledge in terms of what to expect, whatever decision they make, right?
Yeah, absolutely. So yes, I mean, in the prenatal realm, we are definitely dealing with some difficult information, difficult decisions. And so whether it's around sickle cell disease, which, maybe people had some pre-warning about, that kind of got them to get that information, Or whether it's, we did an ultrasound and we see that the baby's heart isn't formed correctly, or there's a problem with the brain structure, or we did testing for things like Down syndrome and we're identifying something unexpectedly. Regardless, these are very, very hard conversations and situations that couples can find themselves in.
Right.
And again, the decisions run the gamut. And although some may come in and say, well, if this happened to me, this is what I would do. If I had $1 for every time I had that conversation before, before testing was done, and then compare that to the decision that was made once that result was available, I would be very rich, because people really do change their minds. When you're in that situation, you may make a decision that's very different than what you would expect that you would, or what you think that other people should. And so that's what makes, even the situation that's come around Roe versus Wade and, the Supreme Court recently, really these decisions around termination, we'll just put it out there, around termination or keeping a pregnancy, adoption is an option, often that people don't consider. All of those are the things that we talk to couples about and talk to families about and help them come to a decision again that is really going to be best for them in that moment, in that time. And really understanding that it's not an easy decision. By the time that I'm talking to most couples, this is a wanted pregnancy. So, rarely am I talking to someone who just simply doesn't want to be pregnant. These are people who are invested at this point. And so it is difficult. But again, that's the role and very valuable role, I think, that genetic counselors have, to be able to have those conversations in a way that's non-judgmental, in a way that really puts the focus on the clients or on the patients or the couple's values, and to the best of our ability, kind of remove our own personal feelings around it and really focus on what's going to be best for this client, because they're really the ones that are going to have to deal with that decision long term, not us.
So why is it, I've always wondered, and I probably know the answer, but I would love to hear what you think about this. Why is it that as women get older, the risk or the probability of them having the couple having a child with a genetic disorder increases, the chance of that happening?
So, and it's a specific type of condition. So, so we know that our genetic information is packaged on what we call chromosomes. And so most individuals have 46 chromosomes, and they're in 23 pairs.
Right.
When we make egg or when we make sperm, we only pass down one of those pairs. So that in an egg, there's usually 23 chromosomes, and a sperm, there's usually 23 chromosomes. However, what we have seen is that in women, as we get older, the chance gets higher that we will give an extra chromosome in that egg. So instead of it being 23 chromosomes, there's 24. Now, to be clear, this can happen in any egg, in any sperm, to any person of any age, right? So I always like to make that point. But the chance, the individual risk, that individual chance for it to happen does get higher as we get older. And, there's been a lot of theories around that, whether, it's the fact that women are born with all of their eggs. And then, of course, we're just releasing one once we start our period, we're releasing one a month. And just as we get older, the machinery that helps to pull those chromosomes apart and, make those chromosomes go where they're supposed to go starts to break down. One theory. Another theory is that perhaps women who are older don't necessarily make eggs more often that have that extra chromosome, but our bodies aren't as well equipped or start to lose the ability to miscarry naturally those pregnancies, because the vast majority of pregnancies that start with that extra chromosome are miscarried. And it may happen very, very early in the first few weeks of pregnancy before you even know you're pregnant. But that's one theory that's out there as well. But regardless, I always like to tell my moms, people start to really focus on these conversations at the age of 35 and older. But even at 35, the risk is about 0.5%. So there's still a 99.5% chance that it wouldn't happen. Even when you get into your early 40s, we're still talking numbers 2%, 3%, right? So the vast majority of the time, chances are going to be in mom's favor that she will not have a child that has an extra chromosome. And if you had a room of children who had Down syndrome, the majority of their parents are going to be under 35, right? So even though the risk gets higher, there's so many more women having children who are under 35. There's just more of the, kind of chance for that to happen. So, so I definitely don't encourage women to go out and try to have children early because they think that, their risk is going to be that much less. We want you to be prepared and in a good place before you have those kids. And really put those risks in perspective. But there are, tests out there as well for identifying that early in pregnancy too.
Okay. So last question about the testing, the prenatal testing. Why the technology now is so advanced. Are they still doing these amniocentesis sort of perform? Are they still performing amniocentesis where they're sticking that very large needle into the to get some placenta material? Are they still doing that routinely?
So amniocentesis, and just to clarify that a little bit, so it does use a needle. It's a thin needle, but does have to have some length to it because
it's a long needle. It's a long needle.
But in any case, yes, to remove small amount of the amniotic fluid. To be able to capture cells from the baby. And then there's, a procedure that can be done a little earlier called chorionic villus sampling, where we do remove a small piece of the placenta. But regardless, those procedures are diagnostic. So they tell us for sure we are getting cells from the baby, from the placenta, that we're doing genetic testing on to give us information about the fetus. And those procedures have a small risk of miscarriage. And so, but for a long time, that's the only options we really had as far as trying to get information about these. Now, over the past 30 years or so, there's been various tests that have been developed to screen for those conditions, to just give us an idea out of a general population who's at a higher risk that maybe we should be offering those diagnostic tests to. And so where we sit now is I would say the vast majority of individuals have access to a test called cell-free DNA testing, otherwise known as non-invasive prenatal screening or non-invasive prenatal testing. Again, that testing is a little bit of a misnomer. Screening is really a better term. But this is where we can actually use maternal serum. So now we just have to get blood from mom, and we can get some pretty good information about that allows us to assess the risk for Down syndrome, for a few other conditions as well. That can be quite informative and can really help us with those decisions about offering amniocentesis, offering CVS in a pregnancy. And so for many women, they choose that route. If that test comes back not showing increased risk, often will not decide to do further testing. And if it does show a risk, there's still an option not to do any further testing. You'd be able to, then some do decide to go on and pursue that further.
Okay. So there's a question from the African Ancestry family. I think it's Nadia or Nadia. I probably messed her name up. I'm sorry. What is the percentage of correct results for most testing? She says that my friend was tested while pregnant and was told that the child would have Down syndrome, but the baby was born without it.
Yeah.
How high is that sort of?
Yeah. So it really depends on the test. So I talked about cell-free DNA testing. Depending on the condition that you're looking at, it gives you different, the percentage is going to differ. And this is really an important point. If anyone pays attention to the New York Times, there was a lot of attention around this recently. So when we think about a test like cell-free DNA testing, for Down syndrome, for a few other what we call trisomies where there's an extra chromosome, it works pretty well. But as we've kind of tried to push the envelope and look for other conditions, that information is not as predictive. And so it's just important to talk to your healthcare professional or a genetic counselor about what those percentages are. It can vary. If someone, if I see someone who has a positive cell-free result for, let's say, Down syndrome, that risk might be 80%. Or maybe 99%, right? It depends. There's other factors that we take into account before we give that number. And so it's important to understand that number is not the same for everybody. And often what you'll run into, if you look on a website or something like that, for some of the labs who offer this, is they'll talk a lot about what we call a detection rate, but that's different than what we call a positive predictive value, which is what is my chance if I have that positive test that, it will come back positive. So that's one thing. The other thing is, before cell-free DNA testing, there was other types of testing that we did through mom's blood, which was not as informative, but we used it for screening. And so I think a lot of it is just the language and the lingo that's used to understand that a test has come back showing a higher risk for a condition versus your baby has this condition. And I think whether it's a miscommunication between the provider and the patient with that language, or, kind of once that person hears Down syndrome, they just go there and, kind of run with that. Like, yes, my child has Down syndrome, and kind of miss this is a chance. But again, it very well can be that provider not explaining it well as well. So again, this is one of the critical roles of genetic counselors, to be able to make that distinction and make it clear and ensure that that's understood and really heard by patients before they leave.
Oh, that's great. I mean, this has been a fascinating discussion. Before we bring Gina back, I want to ask you one more question about, and I think a lot of the family members want to know, what's your day like? Sort of like, what do you do on your average day? What does that look like as a genetic counselor working at Howard University?
So one of the things I have loved about Howard is it allowed me to do so many different things. So I do see patients. I do work mostly in prenatal, but we do cancer at Howard as well. So just today, I actually got results back from a family that had a positive cancer genetic testing result. So we have to work with them. And so I would say I spend about half of my time doing that. As mentioned, I teach, and that's, of course, very rewarding, being able to talk to medical students, graduate students, nursing students about the role of genetics, because genetics really is becoming more than just these individual, relatively rare genetic conditions. It really is becoming a part of general healthcare. As we find more about the genetics of heart disease, cancer, diabetes, et cetera. And then I get to do outreach work, which I really, really enjoy. As mentioned before, we have the Howard University Center for Sickle-cell Disease. And in addition to clinical service and research, another main prong at the Center for Sickle-cell Disease is community outreach from its onset. So being able to go to churches or health fairs and talk about sickle-cell disease, we coordinate free testing for sickle cell. We have big awareness events like a walk, events for World Sickle Cell Day, which is June 19th. Whatever it is, it's very rewarding to be able to do that for the community, to bring that word to the community, and also advocate for individuals with sickle cell, be that in the legislative arena, with insurance. So I get to do those things as well. And then some research too. So my day at Howard is never the same. And I get to interact with some wonderful people, as you were mentioning before. Howard is just a really good place to work. It's a rewarding place to work. So I've appreciated it greatly.
Okay, great. So we'll bring Gina back so we can do the final set. But before we do the, what is it, whack or whack? What is it called again?
Fact.
Fact
or whack.
or whack. Okay. Before we do this, I do want to, I'm going to embarrass Barbara a little bit. You know, she was one of our early adopters early on. She's part of the African Ancestry family.
Woo, woo, woo.
And Barbara, do you remember what your results were back in?
So it's funny you say this because, all right. So actually, I didn't do the test.
Oh, that's right.
My husband did the test.
Right. That's right.
So Rick offered it to me, and I was like, I know my husband would just really love this. So I actually got him to do it. So he is from, I don't want to say it wrong. I know he's from Nigeria. I just can't remember which tribe.
Okay.
And also Niger.
Okay. And it wasn't Fulani. That means it probably was.
It may have been Fulani now that you said it.
Okay.
Yeah,
it could have been
sometimes we see them in both.
Mm-hmm.
Yeah.
That's cool.
So I need to get my test.
Yeah, it's funny because
Barbara, come on in. The water.
I know. I need to get with it.
That's hilarious because I remember I was still working at Howard, and it was probably right before I left, and I gave you a test kit, and you said you were so excited. You was like, "I'm gonna take this home to my husband. I'm gonna get him to do it." And I thought I gave you 2, but
I never came. No, you didn't give me 2.
We have to rectify that 20 years later.
Absolutely.
There's one question that I wanted to make sure we address, Rick. Maria Evans asked, how does African Ancestry maintain your DNA privacy if it is to be used in your health assessment by medical staff? And Maria, I just want to be clear, we don't use your DNA in any health assessment. We only use your DNA to trace your ancestry. We don't sell or share it, and our lab destroys it. So when they talk about health assessments, that's something separate from what we do at African Ancestry.
Right. And we're starting to have that discussion in the community because we think it's important. But right now, we're not doing that sort of testing or providing that health-related services.
Yeah. So your DNA is safe with us. So, Barbara, as Rick mentioned, every week we have a game we call Fact or Whack to see how well the family was paying attention to what our guests were teaching us, and to get test their level of knowledge and understanding. So if you would do us the honor of reading the statement, and then our family in the chat are going to say whether they think it's fact or if they think the statement is whack.
All right. So genetic counselors are able to tell you if you should have children.
Ooh.
Is that fact or whack?
Rick, do you know the answer to? You were like, I don't know if I'm going to know the answer.
No, I know the answer to this.
He cheated.
Okay.
Because, that's a very important statement right there.
Yeah. So it looks like the people who say it's whack, so far no one has said it's fact. It looks like they're all whacks coming in here.
Let's read the question one more time. Genetic counselors are able to tell you if you should have children. Fact or whack? And
Barbara was pretty clear about this.
Yeah, she was.
In the conversation.
That's why I'm able to answer this because she
And I'll say, and this is important. I have definitely had people who did not want to come to see a genetic counselor because they thought that they were going to be told not to have children. So
that means
this is an important point to get out there.
Yeah.
Right.
So is it fact or whack, Barbara?
Oh, it's definitely whack. Definitely whack. Yeah, that gets the thumbs down. For sure.
Nice. Okay. And then the second statement.
All right. If you look like your mother or if you look like your father, then that is who you got most of your strong genes from.
Fact or whack?
Fact or whack?
I love when people talk about this strong genes.
Yeah.
I was like, I don't remember learning about that.
You got some strong genes. Like, what? Strong genes.
We're getting a lot of whacks. People are saying whack. Whacks. Looks like the whacks have it. What do you say, Rick? Fact or whack?
It's whack.
Yeah, definitely whack.
Okay. So is there such thing as strong genes?
I'll let Dr. Kittles take that one.
Oh, is there? Oh, No, there's nothing. There's no such thing as strong genes. You know, we get a mixture of genes from our mother and our father, and the way that they get assorted and mixed up, you know, it's a random shot. You know, it's like rolling the dice in a sense. And so no, there are no. You know, there are certain variants of genes that are dominant. They act dominant, but they're not strong genes that are always expressed in every generation. So I see King Joseph is on here. What's up, Chief? He said that it's warm in LA. He's getting that vitamin D.
Oh yeah, you made a good impression on him with the vitamin D. And
it's beautiful today, man. I was out there growing my plants. It's a gorgeous day today.
Don't run. Yeah, it was beautiful here in DC too.
Yeah, whatever.
It was nice in DC. I want to just emphasize that statement just because, you know, we talked a little bit, I think it was last week, y'all may have talked about it, or at least maybe in that vitamin D conversation, but, you know, talking about things like cancer risk. And I really have heard a lot of people saying, well, I look like my mom and my mom got breast cancer, so I know I'm going to get breast cancer. Or I don't look like my dad and that history is on that side, so I don't, you know, that I didn't get that gene. And so that's what I really want to make sure we abolish that myth, right? So what you see on the outside is just a small percentage of your genomic makeup. So yeah, you may have gotten facial features maybe from, or, you know, those dominant genes that made you look like more like one parent than the other, but you know, that doesn't tell you what your genetic information is. The rest of it is.
Right. So what you're saying, Barbara, is that you might have skin color like your father, but that doesn't mean that you inherited his risk for prostate cancer or something else. And because of that, like we said, that mixing that occurs when the sperm meets the egg, and it's really a random sort of combination of what we call phenotypes and traits and disease risk.
Yeah. I really appreciate the two of you being here with us this evening, especially you, Barbara. I want you guys to put some DNA emojis in the comments to show Dr. Kittles and Barbara Harrison some love for sharing their expertise with us tonight. You're welcome back here anytime, and you have to make sure you give us your mailing address so that we can rectify Dr. Kittles' error from 19, 20, 21 years ago. Everybody.
I was excited to you know, that she was excited to be part of the family. So, you know, we got it through her husband, but now we can get her tested. But
maybe I'll come back and let you know.
You know, she's not from the third planet from the sun. It'll probably be the fourth or the second.
Oh Lord, you said that on video. Now we're gonna have people saying Dr. Kittle said that there are Black people on the fourth planet from the sun. Everybody, listen, thank you for being with us. We got stuff over on the website. We got the 5 things every Black person should verify before taking any DNA test. We got the Find Your Tribe quiz if you're not quite ready to swab your cheek yet. And you can catch this episode and past episodes of the African Ancestry Experience over on YouTube. If you're watching us on the replay, thank you. We want to see some DNA emojis in the chat. Next week, we're bringing more African Ancestry family on to join us. We're going to be revealing one of the newest members of our team, our marketing manager, Jasmine Musgrave, for Mother's Day. We're going to be celebrating her maternal ancestry with her. She doesn't know what it is, and hopefully she hasn't been trying to look in the system to get her results. We have them on lock. But I appreciate, again, all of you being with us. And until we meet again, may you be happy, may you be healthy, and may you be whole. Have a very good night, everyone.
I wanna know ya, Cameroon, Guinea-Bissau, Sierra Leone, gotta let me show ya, Nigeria.